Morning.
Morning.
Recording in progress.
Minister.
Morning, Chairperson. Beautiful Chairperson. How are you?
I'm fine, thanks. And
Good morning, Chair.
Good
Chair.
Good morning.
Good morning, darling.
I'm
Good.
fine.
Good night.
Fine, Sister.
Good morning. Honorable members, I think we need to start. We were waiting for members. I was checking that we were less than 14. So, but now we are more than that. Then we can proceed with our meeting. Good morning, everyone, and happy Women's Month.
Good morning,
Happy
Chairperson.
And I know a lot of provinces today, they are
Happy Women's Month.
happy.
Morning,
Chair.
Happy,
Morning,
beautiful woman.
Morning. I do believe that there are a lot of activities happening today, since it's the last day of our Women's Month. A lot of provinces are having activities where they are celebrating and also doing the closing of the Women's Month. I also know that the ANC Women's League is doing its closing and celebrating in the Free State. And I've learned that even around Giani, they are also having their celebration, and many more others. But to all of them, let me say happy Women's Month. And I believe as women, we're taking care of ourselves and also for others. We are going to start with our meeting, honorable members. And I've seen Honorable Minister Dlamini Zuma is present with us. Thank you very much, Honorable Minister, for coming.
Yes, I'm here. Thank you for.
Thank you very much. Thank you very much, Honorable Minister. I know this department always, the ministers, they do come and present and also attend our meetings. Thank you very much, Honorable Minister. I know State SA is with us and also the Department of Health. Our agenda is there. It has been flagged. The first item is opening and welcome. That's what I was doing. The second one is apologies and adoption of the agenda. Then State SA will present, then we discuss. Thereafter, the Department of Women, Youth and Persons with Disability, before they present, the minister will give an input. Thereafter, the discussion, then the Department of Health. I've learned that the Department of Health will be joining us later. The person who's going to give the presentation is still on her way, so she will join us. But for now, State SA is with us. The Department of Women, Youth and Persons with Disability is also with us. And my former colleague, Sis Faith, is here with us. You are welcome, Sissy. So we're now starting. Mandy, is there any apologies?
Yes, Chairperson, we received 14 apologies. It's from Ms. Nkadimeng, Ms. Masondo, Minister Zulu, Deputy Minister Mafu, Ms. Christians, Deputy Minister Tolashe, Ms. Breed, Ms. Laviskachri, Ms. Boshoff, Ms. Lucas, Mr. Bia, Ms. Piri, Ms. Shabalala, and Mahlengwa is struggling to connect. Chair.
No, thank you very much, Mandy. Honorable members, we have 14 apologies recorded, but that doesn't mean that we are not proceeding with our meeting. We are proceeding since we correct. I've read the agenda with State SA. I don't know who's leading them, who will be presenting. Mandy, can you go down a little bit with the agenda? Thank you very much. Oh, there is the Deputy Director General, Statistic Operation and Provincial Coordination, and the Chief Director, Demographic and Population Stats. Then the Director Health Statistics and the Chief Demographer. Then the Deputy Director Survey Research and the Principal Demographer. I don't know who is going to present to us. Over to you, Stats SA. Thank you.
Thank you, Chairperson.
Chairperson Mantuli, before Stats SA.
Oh,
Sorry to interrupt. May I move for the adoption of the agenda, please?
thank you very much, Mantuli. You are progressive on this Women's Month. Thank you very much. Mantuli has moved for the adoption of the agenda. Any seconder, honorable members?
Yes, Chair. Honorable Sharif will second the agenda.
Thank you very much, Honorable Sharif. You are progressive. Over to you, Stats SA.
Thank you, Chairperson, and acknowledging the Honorable Minister that's here, and happy Women's Month to all. So thank you. I'm Ashwell Jeniker. I'm the Deputy Director General from Statistics South Africa. Greetings and apologies from the SG, who is leading the our Women's Forum in Sandton City. We've got an international meeting and he's chairing there. Thanks. So in the presentation, I've got one introductory slide and a couple of background slides before we get into the health issues that is especially concerning to women. Now, firstly, according to the UNFPA, the right to reproductive health is the cornerstone of development, and therefore it's a global concern to us all. Now, there are international framework like the Sustainable SDGs, our own National Development Plan, and the Medium-Term Strategic Framework. And these framework promotes health, and there's measurements included as to how we should measure that we are making progress on health issues. Now, poor reproductive health remains a major concern and a cause for disease and death among women. And it accounts for 20% of disease burden for women aged 14 to 49. Now, mortality due to breast and cervical cancer is especially a concern here in South Africa, and I'll show you later a slide on this. I just want to do a couple of background slides so that we understand what sort of numbers are we talking about. So at the moment, there's 60.6 million people in South Africa. That was the mid-year estimates for last year. And 51.1% of that were female. So we did the census. So very soon we will be releasing the census, and then we'll be updating this number for you. But everything relates to the 60.6 million people, of which half of that is women that we're presenting. When we look at the provinces, we can see significant differences and higher levels for the numbers for women in KwaZulu-Natal, in the Eastern Cape, and Limpopo. Because remember, in general, women are 51.1%, so all over a little bit higher than men in all the provinces. When we look at our population pyramid, we see that we've got this bulge in the middle, youth. So both for men and women, we are a fairly young nation, which normally leads to a demographic dividend. So it means that our country can move forward. So if everyone is employed, well-educated, and healthy, then our country can move forward. Generally, we see on the red side, the women live much longer than men into the higher ages when we get up the population pyramid. Just before we get the bulge in the middle, we've got the effect of HIV/AIDS, where you see the pyramid is a little bit narrower there. Okay, let's go to sort of health-related issues. In general, we see that women live longer than men in all the provinces. But it's interesting when you look at the Free State, the gap between living in the Free State and living in the Western Cape is 9.5. So if you're in the Free State, your life expectancy is around 62.2 if you're a female. If you're in a Western Cape, your life expectancy is 71.7. So interesting, where you live in South Africa, it's got a significant impact on how long you are expected to live. If you are male, you're expected to live much less. Okay, let's look at the maternal mortality rate. Now, these are the maternal mortality rates within facilities. And we're giving you this number by 100,000, per 100,000 people. So we can see in 2012, the number of people, of females that died is 144. And it's been steadily coming down to 88. But 88 is still alarming. If anyone dies either during pregnancy or during childbirth, and the definition of this is within 6 weeks of childbirth or 42 days. So 1 is still too many. So 88 is still too many. So there is still a challenge for us. It is in many senses, it's good that it's coming down, but 88 is too many that's passing on during childbirth or during pregnancy. So this gives you the same maternal mortality ratio, and it gives it by province. And we can see that it's especially alarming in the Free State. So although the number has come down from 168 to 116, the Free State is still the highest in terms of maternal mortality ratio in facilities. I mean, if you look at that relative to the Western Cape, you can see Western Cape is much lower. Another alarming factor is the fact that in the Northern Cape, the maternal mortality ratio has gone up, and quite significantly so, from 71.3% to 109.9%. So we really want to sort of look at that and see why is that the case. Okay, when we look at terminations of pregnancies, we can see, and this is in the between 13 to 20 weeks. Now, terminating pregnancies before 13 weeks, less than 3 months, is considered more safe, but 13 to 20 weeks is considered more risky termination of pregnancies. And we can see these within facilities is much higher in the Western Cape and in Gauteng. Generally, it's been increasing overall in the country, but Western Cape and Gauteng is the highest in terms of termination of pregnancies. So when we look at the change of delivery between the ages of 10 to 19 years, so delivery between the ages of 10, so these are teenagers giving birth within facilities, and we can see it's been steady over the years, but still very high. If you look, for example, in the Northern Cape, 18.8%, or almost 20% of births that's being delivered there among teenagers is in the Northern Cape. Eastern Cape also 16.9%, quite high. So it's stable over time, but considering that these are teenagers, and if you give birth, it's not necessarily a choice when you're a teenager to give birth to children. So these are statistics that is alarming to us. This slide is about the prevalence of HIV, and we see that it's the highest amongst the age group 25 to 49. And those are all the orange there. And in the age group category 35 to 39, it's been alarmingly, and this is a significant rise. When you, in statistical terms, when there's a rise from 28% to 39%, we call that significant. And in those age groups, 35 to 39 and 40 to 44, among sexually active women, there's a significant rise in HIV prevalence. So these statistics shows us the woman that receives antenatal care, and when they arrive for their first visit, these numbers refer to people that's already on antiretroviral treatment. And you can see in the Western Cape, much higher than the overall for the country, Free State, and it's steadily going up, that at first visit, the numbers are much higher than the average of the country. When it comes to cancer, and it's interesting now how many people we personally know of that pass on or that is affected by cancer, but we can see over time, females are higher affected by cancer than males. On average, it's 5% higher than the males. And over time, you can see it's steadily growing. If we take from 2008 to the last time we measured, which is 2019, and significant rise in the numbers of cancer, people being diagnosed with cancer. And we can see in the age group 25 to 54, women has almost got double the number of cancer cases diagnosed with than males. So the bottom line gives you the males, the top line gives you the females, and we can see in the age group 25 to 54, that is the purple area, women is double affected by cancer. In terms of people passing on, mortality cases amongst women, cervical cancer and breast cancer is the highest in South Africa. And when it comes to cervical cancer, we can see the mortality rates is the highest among Black African, followed by colored females over the years. So the insert slide is showing us right over the years, cervical cancer, highest rates among Black Africans, followed by colored females. So when it comes to breast cancer, the opposite again. Although, so Black African females is the lowest in terms of mortality rate as a result of Black Africans, but we can see over time, coloreds have now surpassed whites in terms of mortality for breast cancer. So in conclusion, so maternal mortality ratio, that's now in facility. So the mortality that appears within facility has declined in South Africa. We can see it reached a high in 2012 and it's come down steadily to 88. So this is a positive trend for us, but it's alarming for us what's happening in the Free State and the Northern Cape, and we should be looking at that. Termination of pregnancies in the weeks 13 to 20 is the highest in the Western Cape and Gauteng. One should also account that these are the provinces that's probably got the most facilities for these. So one should take that into account when you look at these figures. Teenage giving birth between the age groups 10 to 19 is as the lowest in Gauteng and the Western Cape. And it's been stable over time. Antenatal clients that receives antiretroviral treatment at first visit has been increasing across all provinces. And the risk of cancer is dominant among women. And you've seen that in the age groups 25 to 54, it is double than that it is for men. So what we see is that overall, the study reveals that our country continues to make progress in the health of women. However, we need to do more, especially around the scourge of HIV and cancer among women. Thank you, Chairperson.
Thank you very much. Thank you very much, Ashwell, for the presentation.
Thank you.
But the little observation, I don't know, maybe if it's myself only, the presentation that you were just giving to us, it's not the same as the one that has been sent to the Secretariat. And if that is correct, that will be my appeal that next time when you come to present, please, the presentation that you are going to present, let it be the presentation that you send to the Secretariat for members to go through before you come. Thank you very much. Honorable members, this is the presentation from Stats SA. Can we engage the presentation? I see the hand.
Chairperson, oh, my hand was not up. Chairman.
I see the hand of Honorable Jane, Honorable Mananiso, and then Honorable, who's there? I can't see any other hands. Oh,
Take my
Mantu.
hand, Chair. Yes, because I can't. Yeah, thank you, Chair.
Honorable Mananiso, you can go ahead.
Okay, thank you, Chairperson. Let me start by appreciating the presentation by Stats SA. Mine is nothing to do with the presentation, but I just want to check if this particular presentation, can we get it with different indigenous language? If yes, where can we get it? Because I think it is so insightful in a sense that some of us would want to share with our constituencies with their preferred language. Thank you.
Thank you very much. Mantuli.
Thank you, Chairperson. I would love firstly to welcome the presentation. But again, I think I'll join my colleague Nyanga Mananiso here to say, much as one is not going to ask questions or clarities from the presentation, but I wanted just to comment, Chair, to say we understand State SA is just giving us the numbers and the situation at the time. But it is really worrying, the sort of the stats that they've presented to us. It shows that women are still at risk and women are at stake, and you begin to say maybe the relevant department, how can this portfolio committee maybe sort of try and get deeper information from the relevant department as to what are they doing according to these statistics. Thank you, Chairperson.
Thank you very much. Honorable Masiko. Honorable Masiko Jele.
Oh, thank you very much, Chairperson. My apology. I thought that you were saying Masiko because there's Masiko. Maseko Jele. Okay, thank you very much, Chairperson. Good morning, everyone. And also,
Morning.
Yes, let me just firstly start by appreciating the presentation by State SA. But I have only two questions. that I would request clarity on. When you started with the presentation, there's somewhere where you indicated you said something like a poor reproduction. I was a bit confused. I don't want to think that I understand by poor reproduction. I don't know what is it that maybe one can get more understanding in terms of that. I did not want to think that it is poor in terms of poor or poor in another understanding, if I can understand that. And then the second one, it is the issue of HIV being prevalent to women. Maybe State SA can also indicate or maybe advise in terms of saying when they were doing their I know they deal with numbers, but those numbers, they take them amongst the community. They go to the community and get those numbers. But I just wanted to find out if maybe what is it that they have noted? Is it because of the lower or lower I don't know how to put it, but the issue of morality in our community that might cause that? Because I should think that if you are saying it is more on women, is it because one man having to sleep with many women who is infected, who infecting these women, all of them? Could that be the reason? Thank you, Chair. I'll stop there.
Thank you very much. Sorry. Honorable Drucken. Honorable Velma.
Yes, just a moment, Chair. Okay. I just had to make sure that I could see myself. Good morning, everyone, and thank you for the presentation. Thank you, Chairperson. Unfortunately, I put up my hand very slowly because I'm still processing the information in the presentation. Just to ask Mr. Jenica, is it possible to get a breakdown of the statistics, especially with regards to cancer and HIV, for how many people, the breakdown for how many people are disabled who get cancer and also HIV? And the reason why I'm asking is because sometimes the receiving of information or access to information with regards to cancer is quite slow for people with disabilities. And then it's also with regard to health issues. A few months ago, a deaf person, for example, who already had cancer stage 4, the person passed away, unfortunately, but I'm worried, about the access that she had to the information and access to the knowledge about the treatment that she could have gotten. So, for example, by the time that we knew that she had cancer, she's already given up. She didn't want an interpreter because, she would rather just, leave everything. But so my concern is about the information that people receive, especially people with disabilities. Can the statistics be broken down into the different disability groups or not? Thank you, Chair.
Thank you very much. Honorable Gomba.
Thank you very much, Honorable Chair, and greetings to honorable members. Honorable Chair, my question here is about the increasing number of people with cancer. And my concern here is that, do we have any measure that we controlling this spread or the growth of the awareness, the growth of people who are suffering with cancer? How do we think we can assist these numbers to decrease? And secondly, I'm worried about the awareness campaigns, because if people are aware that the cancer is something that is there and that a lot of people are living with, we should be able to save a lot of lives from women and be able to be detected timeously before it can spread and be a serious matter. So my question here is, do we have any other ways of ensuring that there is cancer awareness throughout the country so that we can be able to save lives timeously of those women who are having cancer? The other question here is that in the presentation, I had the presenter presenting that women survive and live longer than men, and men die earlier and faster. I'm so much interested to hear what is it that causes the men mortality more than women. What is it that men are suffering from, and what type of cancers, or what is it that is causing death to men? Thank you very much.
Thank you very much, Honorable Gomba. Honorable members, I'm just checking if there are still honorable members who want to raise questions. If not, then I will give the opportunity to Stats
Yes,
SA.
please. Yes, please, Chair. I've had my hand up for a while now.
Oh, Honorable Sharif.
Yes, Chair.
Oh, okay. You may go
All right.
ahead.
Thank you very much, Chair. Thank you for the presentation. I wanted to first state that ask your stats you're giving us is from 2020. We're now in 2023. I just wanted to see, why is there a delayed stats? Why are we looking at 2020 and not more recent stats? That's the first question. The second question, Chair, is I just want to, agree with one of the previous speakers, and that is to say, Honorable Vilma, is that a lot of the problem is access to information, access to healthcare, access to screening of breast cancer or cervical cancer. And after somebody is diagnosed, we must be realistic and say that the care for cancer is below par in South Africa. Too many people are dying from cancer. Too many women are dying from breast cancer and cervical cancer. And yet our healthcare service hasn't caught up to the rest of the global society in terms of care and medical assistance when it actually comes after diagnosing of cancer. I mean, Stats SA just mentioned that we know too many people that have died from cancer. And unfortunately, when somebody gets diagnosed with cancer in South Africa, it's a death sentence. And so we really need to maybe get the Department of Health to come and speak to us on what are their plans to ensure, one, access to screening, but also access to medical care, so that we can start saving lives of women that are dying from cancer. The next thing is, in the Stats SA presentation, they spoke about 10-year-olds to 19-year-olds being teenagers. I'm sorry, but a 10-year-old is not a teenager. A 10-year-old is a child. And that in itself is a pandemic that we need to deal with, is how and why are children falling pregnant, and what are some of the solutions that we can put forward as a multi-party women's caucus into provinces to ensure, again, access to information, access to contraception, access to healthcare, access to, all of these treatments that can assist young women and children so that they don't find themselves falling pregnant and having to take care of babies when they themselves are still children. So, what this presentation has showed me is that we have a long way to go as a country in women's healthcare. And we really need to hear from the Department of Health and perhaps the Department of Social Development on what are the strategies and what are the plans to move forward so that we can look at decreasing the amount of teenage pregnancies. I think a good option would be maybe for other provinces to benchmark in the provinces like Gauteng, like the Western Cape, like I think it was the Eastern Cape, where these numbers are dropping steadily and gradually, and have the best practices so that premiers know what sort of interventions and I don't know, want to say activities, but interventions and programs that provinces can implement to slow down the rate of teenage pregnancy, because I do think that it's a massive problem, and especially when we come to children. I can't inside of me see a 10-year-old giving consent to have sex with a grown man. So I think a lot more research needs to go into it so that we can find solutions on how do we challenge the scourge of children falling pregnant. Thank you very much, Chair.
Thank you very much. I now see the hand of Honorable Mahlangu.
Good morning.
Mahlangu.
Am I audible, Chair?
Yes, my dear one, you are.
Okay. Thank you, and good morning to you, Chair, and all members on the platform and the participants. Chairperson, mine is just to say, as the members of committees, we need to take this information from States A as an oversight body to make sure that the departments, as and when they deal with their APPs must respond to this States information, because it's information that is there that needs to be attended to. So we need to have plans, we need to respond to this, and we will be accurate in planning using this States SA information. Thank you, Chair.
Thank you very much. Thank you very much. Honorable Mananiso, can I check something? Is it a legacy hand or is it a new hand?
It's a legacy hand, sorry, Chair.
No, thank you very much. Honorable members, it's like we have dealt with all the hands that were there for questioning and also the comments. States SA. Oh, I see the hand of Honorable Majosi.
Yes, good morning, Chairperson, and good morning to all honorable members. Mine would be a comment, maybe, and also a contribution in terms of how then do we sketch the issue of teenage pregnancy. I would suggest that, Chairperson, I don't know, maybe we can even invite, as I serve in the communications, invite your multi-choice and other programs that are playing, because other things that are also encouraging these things is these programs that we see on TV, and our kids, unfortunately, they are exposed to them. So how maybe do we sketch that in terms of also they put on programs that learners and young girls will be able to learn from them, so that all parties are in this challenge, and everyone is fighting for our kids to have a better future instead of them getting pregnant at an early stage. Thanks, Chair.
Thank you very much. Honorable members, we're now going to give time to States SA to respond to your questions, and also to maybe to elaborate on the comments, because some were just comments, some were questions. Over to you, States SA.
Thank you, Chairperson. Let me apologize that the slides is not correct. We will fix that. We will send this version to Mandy. And also, Chair, I do agree that the more people see this and the more understand this, the better we can do in terms of our fight against these diseases. So from Stats SA side, we've got a translation team. We'll translate and then disseminate it as well to yourselves and the committee. We've got the subject matter specialist, Chief Director Diego Iturralde. I'll hand over to him so that they can answer the more technical questions, and then I'll see whatever is left. Thanks, Chair. Diego, let me hand over to you.
Thank you very much, Ashwell. Good morning, honorable members. Thank you for the opportunity to respond to some of these questions. I think let me start off with the one about male mortality relative to female mortality. This is a global trend that is prevalent, whereby we see that from about the age of 45 or 50, male mortality seems to increase, not necessarily because of any specific diseases, but mostly on the one hand because of more high-risk activities that men are involved in, but also because of high-risk occupational activities that men are involved in, such as different types of mining, etc. So this is why, if you look at any population pyramid and you look at the very old ages of 80 or 85 plus, you will see that there's always a surplus of women relative to men. So it may be that in certain contexts, in certain situations, men are exposed to other types of diseases that may impact them, but it's really more about the high risk or dangerous type of lifestyle that men seem to participate in. Then with regards to some of the questions about, well, let me talk about the disaggregation by disability and other statuses, and about this report in general. This report was produced in the 21-22 financial year. It was produced by looking at a variety of alternative data sources. So you will see that we use the District Health Information System, we use the HSRC's HIV survey, the information on cancer comes from the Cancer Registry. These are all data sources that are collected by other institutions that we have been analyzing. And so their time frame is spread out over time. And of course, we can update this report to be more recent if we have access, and if these institutions are producing more recent data. But I think even from within Statistics South Africa, we certainly have the statistical infrastructure to be able to update various of these indicators. So the issue of disaggregation is really dependent on the data producer. So if it is an administrative source and the disability status is recorded, we can report on that. And if it's from a survey, the sample is large enough to be representative of people with disabilities, we can report on that too. So those are certainly some dependencies. And then I think the final point I would want to make before I pass on to some of my colleagues would be around the reasons why we see issues related to HIV, and especially amongst women. Firstly, is that the burden of HIV does fall amongst women. Globally, here in South Africa, it is unfortunately the way that the disease has panned out. And it is ultimately a lifestyle disease. Sometimes it's a lifestyle that is chosen, but very often it's not. So what we are seeing, the high rates of HIV prevalence amongst women between 20 and 49 can be a reflection of the vulnerability of women in the societies in which they live, where very often they do not have the choice about their sexual activity and the dangers that they expose themselves to. So I think that the high rates of prevalence in specific age groups should be seen in that particular context. But as I said, there are other members of the team with us. We have Ms. Olga Masebe, who is the director for births and deaths in the demography unit at Stats SA, and Ms. Ramadi Mejamaji from our Health and Vital Statistics Chief Directorate, who compiled the report on the Cancer Registry. So if I may, let me pass over to my two colleagues to maybe add on to some of the responses that I've made. Thank you.
Thank you. Who's going to act? Mr. Gineka, is there anyone who's going to act?
There goes the team there.
The team is there, but I don't know, or I'm not sure if they are have something to add.
There was an issue raised concerning the indigenous languages.
Ramadimeja, go for it.
Thank you. Good morning, honorable members. I'm going to respond to the... Sorry?
You may go ahead.
Okay, I'm going to respond to the questions on the cancer, which, as has been emphasized, is a real problem. Some of the strategies we need to reinforce as a country are to sustain the rollout of HPV, or the human papillomavirus, which causes cervical cancer. Ensuring that adolescent girls receive this vaccine can protect them in their adult lives from development of cervical cancer. And another strategy is to strengthen cancer screening services to ensure the early detection of cancer, because late diagnosis of cancer contributes to the high mortality. And then health promotion is also key to reducing mortality due to cancer. Women need to be empowered to check their breasts for suspicious lumps and seek care on time. So those are just some of the strategies we need to work on to reduce this epidemic due to cancer. Thank you.
Thank you very much.
Thank you. The issue that I raised about poor production is maybe a function of my poor grasp of the English language. I don't know what that could have meant. So I'm sorry, Mamjela, I don't know what I said there. It's interesting, we've got statistics of children as young as 11, 12, 13, and 14 registering births at home affairs. So this is especially alarming, and I'll ask Diego to see if we can make those statistics available as well, because I think the more we are aware of these, even if it's alarming and hurtful, I think we can start to hold people account, or we can start campaigns, and we can understand the problems more within the areas. I mean, from our side, we want to make the statistics available as much as we can.
I'm busy sharing the meeting. So sorry, I forgot. So sorry.
Thanks, Chair.
I'm sorry. Yes.
Yes, thanks, Chair. I think that would be all from our side.
Thank you very much. Is there any other?
Yes, it's Olga Budhelo from Status Aid, the Director of Birth and Deaths. Thank you very much, DGG. Thank you very much, Diego. I think you have answered the question explicitly. So I'm just going to add on some few points that Diego talked to. Firstly, the disaggregation data by some segment of the population, like disability. Now here, when we are talking about the prevalence, we are talking about all the people who are diagnosed with HIV/AIDS to the total population. So in this instance, I believe that the disabled people are also included here who are infected with HIV/AIDS. And because this report is from HSRC, as Diego has alluded to, I think we have to talk to them, to interact with them in this regard. The second one about the DDG tried to answer about the poor reproduction. This only means that not poor as in poor. This only means that is access to reproductive health, an issue of contraceptive use, access to information about sexual behavior of these girls. And this can be attested by the slide that we have seen on deliveries of 10 to 19 years old on one of the slides that are increasing. And this is a concern for us because it shows that the programs that are being put in place to decrease this teenage pregnancy are working, but they're not working that enough because we want to see these girls at school. They are not supposed to be pregnant. Therefore, teenage pregnancy in South Africa is still a scourge. I think these are the only ones that I wanted to emphasize on. Thank you very much.
Thanks, Olga. Thanks, Chairperson. That's from Stats SA.
Thank you very much, Gineka, for your response and clarifying on some of the questions that has been raised by members. We now proceeding, honorable members. I will now give an opportunity to the Honorable Minister to give an input before we get the presentation from the department. With Stats SA, if you feel like leaving for now, you are given that opportunity to do so. And thank you very much.
Thank you, Chair.
Thank you very much, Chairperson. And thanks for giving the department this opportunity and for celebrating Women's Month. In the interest of time, I want to just say before the presenters present on the topic that you gave us, I would like to introduce something. Maybe we can have a discussion on another day on it. As the department, we said in our budget speech that one of the things that we are going to do is to establish a co-op bank for women, youth, and persons with disability. That process is underway, and I would love to get an opportunity at some stage to bring a team to brief the Women's Caucus on it, because we would like support from you as the Women's Caucus as well for that initiative. But otherwise, because it wasn't on the agenda, I would just say it's something that really as the department, we feel strongly about. And I must say we are getting support from women, but we need more support. To register the bank, before we even register the bank, we must register a cooperative financial institution. We need a minimum of 200 people, but we've surpassed that number now. We're at 300 and something, but we need a lot more people. And the minimum shareholding for that is 500 to be a shareholder in the bank. In the bank, you need to put 500, but we are saying 500 plus 100 because the 100 would be for the administrative fees to start with. So I would like in future to have an opportunity for us to brief you on that, because I think it's an important initiative for women, youth, and persons with disability. But otherwise, the team is here to talk about the sanitary dignitary program. But I also want to just say as a disclaimer that though the department is the one that fought for this, but the money is given to the provinces. Treasury sends the money to the provinces, and the provinces spend it in the way they think. So we presenting something that we are not in control of. Thank you very much. I'll ask the team to then present. Thank you.
Thank you very much, Honorable Minister.
Chairperson, are we allowed to proceed, ma'am?
Yes, you should proceed. The chairperson has asked for the presentation. Thank you.
Thank you very much, Chairperson, to the members of the Multi-Party Women's Caucus, the Minister, senior officials, and colleagues. Chairperson, I will first speak to the first segment of the presentation, and then my colleague, Mr. Shongo, will speak on some of the suggested actions to take to correct some of the anomalies, especially in the provinces. My name is Sipio Machoba. I'm the project manager for the Sanitary Dignity Program. Firstly, by way of introduction, Chairperson and members, just to indicate that the inequities on sanitary dignity was compounded by inconsistent and uncoordinated provision of sanitary requirements across the country. Previously, there was no national law, policy, or framework guiding the achievement of equity in terms of access to sanitary dignity for indigent women and girls. The provision of sanitary requirements to indigent women and girls was dependent on provincial priorities, and in most provinces, there was no financial mandate at all. Also, just to indicate that the Department of Women, Youth and Persons with Disabilities developed a sanitary dignity framework document in an effort to ensure that indigent girls and women are afforded the opportunity to manage menstruation in a knowledgeable, safe and dignified manner, hence the distribution of free menstrual products to selected beneficiaries. The sanitary dignity framework was developed and approved by Cabinet in 2017 with a few suggestions for amendments, and that it should take an incremental approach due to budgetary constraints. Ideally, it has been stated by civil society and most feminists that it would have been a good thing if this was to take a universal application. In other words, all women and girls receiving these products. But because of budget constraints, the South African government has decided to identify the most needy, that is the indigents, that can, in the present moment, benefit from this program. So that is why Cabinet suggested a phased approach. Apart from this being an intervention, Chairperson, in ensuring menstrual health, as well as sexual and reproductive health rights, importantly, also Cabinet noted that this is a basic human right for women and girls. Further, menstrual health also links with hygiene, hence school infrastructure has to be addressed in terms of water supply, sanitation and hygiene. Hence, the Department of Women, Youth and Persons with Disabilities works closely with the Department of Basic Education in looking at sanitation gaps in terms of public schools, especially with the SAFE initiative, which is sanitation appropriate for education. It is a unit that is based at the Department of Basic Education. Also to indicate that, as the Minister has indicated so eloquently, that we barely touch the budget. This equitable share that goes to provinces, we barely touch it. It goes straight to the provinces, and then the provinces has implementing departments that actually implement the program, depending on the choice of each province. In one province, it would be the Department of Education, and in others, it would be the Department of Social Development. Now, these are the indigents, chairperson, that have been identified as part of the beneficiaries from this program. That is in accordance with the Sanitary Dignity Implementation Framework. The first category of beneficiaries is exactly the one that we've just been talking about right now. That is the quintiles 1, 2, 3 schools. Those are no fee-paying schools, inclusive of special needs schools as well as farm schools. And in the 23-24 financial year, the budget is 235 billion, as indicated there on the screen. So from 2019 to 2023, about 4,303,709 learners have been reached through this program. Now, that is through this equitable share allocation that we've been talking about. Now, to also demonstrate that this is an expansive program and is also integrated, other sister departments also play a role beyond just this equitable share allocation. A typical example is that from the Department of Higher Education and Training, through NEFSAS, through the NEFSAS grant, that is the National Student Financial Aid Scheme, all NEFSAS grant beneficiaries, chairperson, receive a stipend of 290 per month. Amongst other reasons for that is for them to be able to access menstrual products, things like toothpaste and deodorants. And basically, this is for the dignity of female students at university and female college level. Thus far, in terms of the population of NEFSAS beneficiaries that benefit from this program is about 429,000, which is quite a sizable number in terms of those NEFSAS beneficiaries. Now, from the Department of Social Development, which also plays a role in this program, also menstrual products are distributed to child-headed households through the social relief of distress consignments. The exact statistics, in as far as that, chairperson, was still trying to get, we are working together with DSD so that we have the correct number in as far as how many child-headed households are actually reached through these interventions. Also through DSD, again, women also receive these products in orphanages, places of care, as well as places of safety. And also in public, through the Department of Health, in public health hospitals, chairperson, women in psychiatric and maternity wards receive free sanitary products. Again, the exact statistics about this, we are following through so that we actually have impeccable numbers in as far as this is concerned. And also, lastly, in terms of the Department of Correctional Services, the Department of Correctional Services also issues free sanitary pads to women inmates in all South African correctional centers, and the number of those is about 4,000. And also just to indicate, chairperson, that as from April of 2019, National Treasury pronounced a zero VAT rate on sanitary pads. In other words, the logic is that since that period when this pronouncement was made, it ought to be much better in terms of accessing these products by girls and women when they go to retail. But this is something that we are still going to work through with National Treasury to examine exactly the impact of that zero VAT rate, whether before and after the pronouncement of that zero VAT rate, has the position changed in terms of being able to access these well-needed products. And then the next slide, Chairperson, is left on my screen. If I can just be helped to retrieve the screens. Thank you very much. It's back now. We can move to the next slide. The next slide, please. We've been through this one. Thank you so much. Chairperson and members, this is merely just an illustration to you what the equitable share speaks to, and also to indicate that this is not an equal share, it's an equitable share, which means that the disbursements of the budgets to provinces is based on population density, the layout of the land, the expansiveness, the size. So out of that 235 million, then it is dispersed to provinces. This has been the case since 2019-20 financial year. And as you can see there, this is segmented into provinces that implement this program through, firstly, the Department of Education. Those on top implement the program through the Department of Education, and then there at the bottom, it is implemented through the Departments of Social Development. If you just take a cursory look at these colleagues, chairperson and members, you go through it at your own time. But just to say quickly, the biggest recipient of this program is KZN. If you see KZN there at 55 million, and then it is also followed up by Eastern Cape at 42 million. The lowest budget is received by the Northern Cape at 5 million. But can I just say one quick thing about Gauteng? Gauteng receives an amount of 28 million, but Gauteng is the only province that has its own budget, which basically complements this one. Gauteng has a budget of 120 million to add to this 20 million, because they have a unique program in that what they do is that they distribute what they call dignity packs. It's not just disposable sanitary pads. It includes toothpaste, deodorant, soap, and also for learners with albinism, there is a lip balm, sunscreen, and also hats, because that's very important for learners with albinism. Also, that includes, in certain instances, the uniform. So they have a more broader basket of services in as far as Gauteng is concerned. We can then pass the slide. And then in terms of opportunities, in the next slide, after this one, after the one on the equitable. Yes, thank you very much. In terms of opportunities through government procurement, what happens is that provinces go through procurement processes, chairperson, and they then appoint suppliers to then take these well-needed products to the schools. So what we have done as a department and through the policies to say that if there is to be any economic opportunity at all out of this program, women, youth, and persons with disabilities owned enterprises must primarily be able to benefit from the public procurement process. So this process can go through manufacturing, distribution, storage, and waste collection and disposal. So there are opportunities in that value chain. And then, of course, our role is to also give broad specifications in order to guide provinces when they conduct those procurement processes. And also for purposes of product safety, because we are very, very astute about the issue of protecting girl learners, is that we are saying that any menstrual product that is distributed to public schools in South Africa must bear South African Bureau on Standard safety certification, so that we avoid a situation where there is an illicit proliferation of harmful products, which would then put government in a very problematic space in terms of reputation and also possible litigations. That's why SABS compliance is so important. And then the next slide. The next slide, please. Then speaking to, can you go back? I think the slides moved too fast. Yes, thank you, right there. If we can just now, going towards the tail end, Chairperson, speak about the challenges in the program thus far, to mention that one of the first challenges that we have is delayed procurement processes. And the delay in procurement processes then obviously affects the learners, because we always say this to provinces that learners do not stop menstruating because of delayed procurement processes. That is why it's important that when these procurement processes are being conducted, provinces are very astute and very efficient in terms of their own project planning and management, as well as execution. So this phenomenon is prevalent right now in Eastern Cape, Free State, and Limpopo. In Mpumalanga and Northwest, the issue has been addressed by the Department of Women, Youth and Persons with Disabilities. Firstly, if I could speak about Limpopo, the program in Limpopo, from the very word go in 2019-20, there were always procurement processes, and they were always bickering about a lot of issues where it seemed as if there is no adherence to policy in as far as the processes are concerned. But the situation improved thereafter. But then in 2022, there was a court litigation where one of the bidders actually indicated that there were flaws in the procurement, in the appointment of the current service provider. Therefore, after that, the court judgment then came with a judgment that stated that the program must stop because the process has been declared null and void. Now the province has to go through new procurement processes and now have to follow as quickly the injunctions of the Sanitary Dignity Implementation Framework. So currently, what they have done when we met with them is that they have, just to mitigate the fact that for a very long time, learners have not been getting these products since mid-2022 up to now, that they have disperse the budget to school authorities so that the school authorities can directly purchase sanitary pads and give to the schools. But we have asked them to provide us with a project plan in terms of that, so that they can ensure that there are efficiencies in doing so, and that the correct numbers are determined, and that also when they buy, when the schools buy at the retail, they should be guided, because we're still talking about women-owned youth and persons with disabilities enterprises. So there is a temptation there for Chairperson for schools to just go to big retailers. I don't want to mention their name because it is easy to go and buy, and then in a way not comply with the injunctions of policy in terms of benefiting those designated sectors. So it's those kind of issues that we at Limpopo are working on to ensure that at least this is done appropriately. If we can then move to the next slide. And then with the Free State, this is the most alarming situation, Chairperson, because for 2 financial years, Free State has not distributed sanitary pads to learners at all. We have met with them. Again, it goes back to issues of procurement, supply chain management issues, delays that at times you can't get a sense of exactly what is the epicenter of the issues. We've met with them, and now they say that they are starting the process in earnest. They're at the specification stage in terms of the project. They have also taken the route of taking the budget directly to school authorities to purchase these needed menstrual products. And they have also expressed the same concerns in terms of how this should be done to ensure that there are processes and controls to ensure that that handing over directly to schools is well managed, because some schools are more astute than others in terms of managing these issues. So those are the risks that are involved. And then with the Eastern Cape issue just arose into the 2024 financial year, where in the first quarter of this financial year, because again of delayed procurement processes, they will not be able to distribute. But now in the second quarter, we are aware that we have started distributing, but we are going to have a quarterly task team meeting in September, wherein they are then going to give us reports in as far as how far they have gone, together, of course, with the Free State and Limpopo and the rest of the provinces, because that September quarterly task team meeting is meant to obtain reports from all provinces, and then we can see how we can move forward in improving and making the necessary interventions. Next slide, please. Now, to speak about the interventions that we have made, Chairperson, to address sexual and reproductive health rights issues, DWYPD and United Nations Population Fund have embarked on a pilot project in 5 schools in Alfred Nzo, as well as 5 schools in Tudela education districts to address menstrual health issues, teenage pregnancies, bullying, contraception, as well as testing the efficacy of the reusable and rewashable sanitary towels, which is possible if learners are comfortable with them. They could complement the current disposable sanitary pads. So that is one of the processes that were engaged in those 2 pilot areas. Secondly, also to say, the department is conducting water supply, sanitation, and hygiene assessments every quarter in provinces to look at the extent of the girl-friendliness of toilets, because it's very important that these issues of sanitation and hygiene are looked into within the context of girl-friendliness of toilets. For instance, when a learner changes her pad, is the toilet cubicle safe and lockable? Can that dignity be afforded to the girl learner? Also, availability of water and soap to wash after that. Also, availability of disposal bins and toilet paper. So that is one of the issues that we are looking into. There are very good examples of good girl-friendliness in some schools, especially in rural provinces. The situation, as you can imagine, Chairperson, is quite horrendous. So those are the kind of issues we are working on together with the Department of Basic Education and other sister departments. Further, to say that the Department of Women, Youth, Persons with Disabilities, UNFPA, UNICEF, and civil society are working on a national plan of action to combat teenage pregnancies and develop a new theory of change and establish why current initiatives have not been effective. We have met twice, and then in September now we're going to actually develop action plans. And some of the issues already point to lack of integrated planning and execution, because there are very good programs in certain segmented areas nationally, Chairperson. But the fact of the matter is that if it's not integrated, then that obviously compromises issues around effectiveness and impact. Also to say that the department is assessing the impact of age-appropriate comprehensive sexuality education, which is rendered through life orientation subjects in South African public schools. In other words, we're looking at the issues of sexuality. How are they taught in class? Are the teachers well equipped in doing so without constraints of religion or culture or some other prejudices that might be there as influenced by society? And we are going to obviously work very closely with DPE or Department of Basic Education so that we can see, therefore, to what extent can there be improvements in as far as that life orientation subject? Because the advantages of that is where you have a bulk of students congregated in the same space that is within the boundary of schools, where male and female learners are there, which means that in terms of reach and impact, it's an important low-hanging fruits so that learners understand comprehensively sexuality education issues and have a correct understanding and be well in control of their bodies as well, and be able to take astute and well-considered decisions as they grow up. And also lastly, to say that the department is a member of the Integrated School Health Program, which is managed under the auspices of the Department of Health, and we work with the Department of Basic Education, Social Development, and others in an integrated manner in terms of looking at improvement and improving school health issues. Next slide. Then in conclusion from my side, Chairperson, before Mr. Shongwe comes in, is to say the overall picture, we think, reflects the reality that government has made considerable strides in ensuring that girls and women's dignity is addressed and that period poverty is being mitigated. But it is important to note that provinces need to address and improve on their systems and controls to ensure that there is greater impact, because as the minister has correctly indicated that DWIPD is not an implementing department. So we don't have the extent of reach, or there are certain things that we're unable to really intervene in tangible on the ground, because ours is to monitor, conduct interventions, but the real implementers, which are the provinces, are the ones that need to improve on their systems and controls. That is why we've developed a monitoring and evaluation framework for them. And we've also workshopped thus far 5 provinces on proper monitoring as well as evaluation aspects in order to assist them in the execution of the program. Also to indicate that, yes, we will continue as well to monitor the program through the quarterly task team meetings that we hold with provinces, and also conduct provincial visits from time to time. And also what we will do in the 2023 financial year, we'll do a comprehensive evaluation of the entire sanitary dignity program, because it would have been a completion of the MTSF period. I think this is a correct period where it can then be able to actually say, from its inception in 2019, 20 up till now, which would be 24-25 period, how have we really fared in terms of everyday space information, and what improvements can be done going forward. And also lastly, to say that DWIPD will also consider IGR interventions for non-compliant provinces. Thank you very much, Chairperson, for your indulgence. I know this has been a little bit long. If I can then, through your permission, then request Mr. Shongwe just to speak on some of the interventions that we are trying to make to ensure that there are improvements at the provincial level. Thank you very much, ma'am.
Thank you very much, Mr. Shongwe.
Thank you very much, Chair. Good morning, Honorable Chairperson. Good morning, Honorable Minister, and Honorable members and colleagues at large. Chairperson, I'm going to present one of the interventions that were undertaken by the department to ensure that the sanitary dignity program achieve its objectives and it's administered well. Can I request we go to the next slide, Secretariat, please? Oh, no, I'm sorry. Let's go to the previous slide for background. Chairperson, in 2021-22 financial, the department assessed the adequacy and effectiveness of oversight and reporting system of the sanitary dignity program, and those results reveal the following weaknesses. There was unreliable information which was received from the provinces, and that information was used by is used by the department to compile the quarterly reports on the progress made on the implementation of the sanitary dignity framework. Secondly, the assessment also revealed that there was no database and statistics of the beneficiaries of the program that was maintained, in the provinces, and it also impacted on the department in various ways, including that the department was not in a position to assess the impact of the program as to or progress as to how far are we doing with the department. Then the department, as an intervention, took a decision to coordinate an audit in the provinces on the sanitary dignity program, focusing mainly on the controls, risk management, and the governance processes. Because the view was that if those, the controls, risk is adequately managed and there are sound governance processes, the likelihood of the program to achieve its objectives will be achieved. Then the department requested the internal audit functions in all 9 provinces to review the adequacy as well as the effectiveness of controls, risk management, and governance processes in the provinces. Then all nine provincial internal audit functions accepted the request of the department to review the sanitary dignity program. Currently, at the moment, 6 provinces completed the review of the program. 3 provinces, that is in Mpumalanga, Limpopo, and Northwest, the reviews are currently underway, and all of them, they've committed or made a promise that they will conclude their reviews before the end of September, Chairperson. Next slide, please. These are the results which were obtained from the 6 provinces that has concluded the reviews, Chairperson. We've summarized of them. Firstly, on governance of the sanitary dignity program, those are the systems that are put in place to direct, control, and manage the program in the provinces. The governance processes were found to be inadequate and ineffective, as there were no memorandum of understanding between the department and the provincial departments. On this particular matter, the department has finalized the memorandum of understanding and processed them to the provinces. The provinces are delaying in terms of concluding those memorandum of understandings. The other issue that was also identified is that the provincial committees, that is sanitary dignity provincial committees that are supposed to be established in terms of the sanitary dignity implementation framework, there are not terms of references that are developed for those particular provincial committees. And the committees, the provincial sanitary dignity committees were not established in 3 provinces. That is Free State, as Mr. Mashowa has alluded, that Free State was not distributing the product and services in the previous 2 financial years. Eastern Cape as well as KZN. Only 1 province included the sanitary dignity program in its in the APP, annual performance plan, for the year. That is Gauteng. They managed to have the program in their APP, and the risk related to the implementation of the sanitary dignity program were not incorporated in the risk register in all provinces. All 6 provinces that have submitted, that is to say, and they also give a rise to the question whether are the risks identified and adequately managed. That relates to this. It's one of the areas that was identified. The above weaknesses on governance are attributed to inadequate monitoring and oversight by the provincial and national committee on sanitary dignity. You are saying this because those committees are empowered to monitor the implementation of this of this particular program, which means if the oversight and monitoring can be enhanced, we might be able to see some improvement on governance processes. The other area that we've also was looked at by the provincial audit functions is the access to sanitary products and services. In all 9 provinces, control processes on the identification and approval of sanitary dignity program beneficiaries were found to be inadequate and ineffective. Furthermore, the water sanitation and needs assessment was not conducted. As a result, there was no water access, sanitation, and hygiene infrastructure plan in place in all provinces. The above can be attributed to inadequate oversight by the provincial committees and non-establishment of Indigent Sanitary Dignity Committee. The Indigent Sanitary Dignity Committee is a committee that operates at a local level. At a local level, for instance, at schools, the schools that are participating in this particular program, they're supposed to establish this particular committee. Is the one which assists in terms of identifying the indigent girls that are eligible to be beneficiary of this particular program. And the other thing that contributed to this, there are no standard operating procedures for WASH in place at provinces. Then the other area that was also looked at is the procurement, storage, and distribution planning for the sanitary dignity program. What was found is that the control processes on the procurement, storage, and distribution for sanitary products were inadequate and ineffective. That conclusion was reached on the basis that the bid specification did not include the requirement for skills development. The bid specification did not indicate preference will be given to local business owned by Black females, classified as youth, and with disabilities. These areas are, requirements are some of the requirements that are required by the Sanitary Dignity Implementation Framework, which were found to be lacking. And the lack of storage space, as well as standard operating procedures for storage on sanitary products, and the lack of systems to monitor the delivery of sanitary products were some of the weaknesses that were identified. The above, the identified weaknesses can be attributed to the bid specification not reviewed by the National Committee, as well as the lack of storage and distribution plans, which are not in place. The other area that was also looked at is the Provincial Sanitary Dignity Committee oversight responsibility, whether these committees are existing and they are performing their responsibilities as outlined in the Sanitary Dignity Framework. The result of this, the committees were not established, as I have indicated earlier, in the Free State, as well as in the Eastern Cape. In the Eastern Cape, maybe I need Chairperson to clarify one thing, is that the Eastern Cape province indicated that this committee is established and functional, but however, the provincial team that was reviewing that was not provided with the appointment letters, was not provided with the minutes of the meetings that this particular committee held. And on that basis, the team concluded that the committee is not established there because there's nothing to support that is in existence. Then continuing, and the committee was inadequately composed or constituted in KZN chairperson, the sanitary dignity implementation framework stipulate exactly how this committee should be constituted, and it's constituted by various provincial departments who've got a role to play in terms of ensuring that the sanitary dignity program is well implemented in the province, chairperson. And in KZN, we find some of the key departments, provincial departments that are supposed to be part of this committee are not part of this particular committee. Chairperson, it can be attributed to the lack of initiative by the provincial directors general as the custodian of the sanitary dignity program, because the sanitary dignity implementation framework empowers the director general to be the lead people in terms of implementing this particular program. Then next area, chairperson, which I've also indicated, is the functioning of indigent sanitary management committee, chairperson. As I've indicated, that this committee is a committee that operates at a grassroots level, is the one which assists in terms of identifying and maintaining the records of the beneficiaries of this particular program. In all 9 provinces, chairperson, the indigent sanitary management committee were not established, except in Gauteng, chairperson, which chairperson, the Gauteng province used the school-based support. That is to say, that is the committee that is in existence in Gauteng, as the previous speaker has indicated that in Gauteng, they don't focus only on sanitary dignity. They've got a program for what they call dignity packs, whereby they disembed over and above the sanitary products, also your soaps, toothpaste, and the likes, just to enhance to improve the dignity of indigent people in our country, chairperson. Then Gauteng is using the school-based support to perform the work of indigent sanitary dignity committee, chairperson. The lack of establishing this indigent sanitary management committee, chairperson, can be attributed to the lack of oversight by the provincial committee, chairperson. The other area, chairperson, which is very key, which is very key in terms of us knowing who are our beneficiaries, also to be able to know who's entering the sanitary dignity system, who's living it, as well, which will assist us to assess the impact that we are making to the community, is the record keeping, chairperson. The control processes on the records and the database of sanitary product and services beneficiary were found to be inadequate and ineffective in all provinces. This can be attributed to the lack of standard and uniform record-keeping systems across all the provinces, chairperson, and over and above, chairperson, although not recorded here, the oversight by the provincial sanitary dignity committee also needs to be enhanced to improve this particular condition. Without getting this particular area right, chairperson, it will be difficult to assess the impact that this particular program is making. Then next slide, please. Chairperson, as a department, what we are recommending. Hello, Chairperson.
No, I wanted to say, while they're still busy, wanted to to put it on the screen. Can you please go ahead, because we still have another presentation after your good self.
Thank you. Thank you, Chairperson.
Thank you.
Thank you. As a department, what we are recommending, Chairperson, is that the lead provincial department in each province should expedite the implementation of the following activities. Number one, the conclusion of the memorandum of understanding with the department. It should be concluded as soon as possible. Secondly, the inclusion of sanitary dignity program in the annual performance plan of the responsible or the lead provincial departments. In that way, we'll also enhance accountability for the program, monitored regularly. The next recommendation, performance of risk assessment to ensure adequate management and monitoring of risk of the sanitary dignity program. Another recommendation, the department recommends that the establishment of provincial sanitary dignity committees and indigent sanitary management committees in all instances where it was found that those committees are not established. We also recommended that the development and approval of the terms of reference for the provincial sanitary dignity committees. We also recommended that the development and implementation of processes for the identification and approval of the qualifying indigent girls and women. And that process is very key to be established. Development and implementation of the process of the processes, procurement, storage, as well as the distribution plans. Also, it needs to be developed as soon as possible. Assessment, the needs on water access, sanitation needs to be conducted as soon as possible, as well as the development of wash infrastructure plans and the implementation plans. They need to be, it needs to be expedited. The department also overviewed that at the provincial level, the records management systems needs to be developed so that there is a proper way that is uniform across the province as to how the records needs to be maintained of the beneficiaries of the sanitary dignity program. The next one is ensuring that the progress reports on the implementation of sanitary dignity program are supported by adequate and reliable evidence. The reports that are submitted to the department on a quarterly basis, they need to be supported by evidence so that we can have a certain level of comfort that what we are producing as a report and submitting to the public and the parliament, it's the true reflection of the situation in the ground. We also recommend that national sanitary dignity committees, as well as the provincial sanitary dignity committees, should strengthen the oversight on the implementation of the sanitary dignity program. The directors general in the province should implement the systems to monitor the administration of sanitary dignity program in their provinces, Chairperson. Chairperson, those are the recommendation of the departments, which will follow through the provincial internal audit functions, Chairperson, to ensure that all those recommendations are implemented at a provincial level with a view of enhancing the management and the administration of the program in the provinces, Chair. Next slide, please. This is the end of the presentation, Chair.
No, thank you very much. Thank you very much, Mr. Shongwe and Mr. Machoba. And thank you very much to the Honorable Minister. In your opening, you did mention the issue of establishing of a co-op bank for women, youth, and persons with disability in your department, of which you are lobbying this caucus to support. Indeed, Honorable Minister, as this caucus, we are going to support that, or we are ready to support each and every initiative as long as the initiative is for the support or the empowerment of women. Thank you very much. Honorable members, can we engage the presentation? Honorable members, can we engage the presentation?
My hand is up, Honorable Chair.
Who is there? I see Honorable Gomba, Maseko Jele, Honorable Druken, Honorable Siminya, and who else? I see only 4 hands for now. Okay.
Yes, thank you
Honorable
very much.
Gomba.
Thank you very much, Honorable Chair. Honorable Chair, let me start by welcoming the presentation. Honorable Chair, my first question here is about the provinces. I think he mentioned Eastern Cape and Free State, and the other province, which is KZN, which failed to actually form the team, what you call it, the structure that is managing these sanitary towel issues. Now, I want to find out, because in some of them provinces, he mentioned the fact that they say they were never told, and therefore there is no proof there will be no proof of the existence of the structure. This is clearly a defiance to the mandate of the government of the day in ensuring that they deal with the issue of poverty and inequality, you know. And the officials from such provinces refuse to come and intervene or come in and do their work to enhance the mandate of the government by forming those structures to ensure that all these programs run efficiently. It therefore makes me to raise a question to say, were there any consequence management which were processes which were implemented to those who are rejecting to or refusing to formulate structures that will help the processes of this government to unfold? That is my question. Any other, or we just leaving it like that to say, no, the structures were not followed, they were not formed or formulated, and therefore it's fine and well and good. And the poor children suffer on the ground because of insensitive officials who don't want to take the mandate of this government of ensuring that there is equality and alleviating poverty. That's my question, Honorable Chair, because this is really very bad. We come with good policies and plans, but officials are refusing to do that, and there's no consequence management to that regard. Thank you very much. Thank you very much, Honorable Chair.
Thank you very much, Honorable Gomba. Honorable Maseko Jel.
Thank you very much, Chairperson. And also thank you to Mr. Mashoba for your presentation. And also, even though indeed just echoing the words of Honorable Gomba, it is very disturbing. In actual fact, this matter of sanitary program has been long overdue. It's supposed to have been settled by now. We still experience such problems. I don't know if people are serious in assisting us in getting this right. I'm saying this because most of the problems, in fact, I'll just, before I can even go further, there are some areas where this program might not be reaching the people that are supposed to be reached. I'm saying this because in my area, I want to make an example. In my area, I have had two girls who every month I give them sanitary pads. And my question, in fact, I started when they were at the primary school. So my question, when we were presenting, was that if that program is there in schools, is it how efficient it is? Because at least now they're at the high school, and it is then now I get relief. I'm not even sure if it's a relief of maybe because they are supposed, sometimes when they see me passing, they'll tell me that, Mama, we have forgotten and all that. But now I can see that they are no longer that much. I'm saying since last year and the year before that, this was happening. So my worry is that, is this problem indeed reaching the schools? I heard that you have areas where you are distributed. The sanitary pads are distributed, orphanage and the high school, the colleges and the universities. But I wanted to find out at primary school, is this program really there at the primary schools for those little ones? Because they start with their menses at about from 9, 10. Some, it depends with the child. So that is my first question. But on the second one, Chairperson, it is on the issue of procurement. The procurement of these sanitary pads by women. I did not get from the presentation maybe where Mr. Shoba is indicating that indeed women are getting this. I heard when you were presenting that, but I did not get it clearly, because for me, this is the program where women must benefit. There is no way that, in actual fact, this is the program where we need to be biased, because it talks to us. It is women who are supposed to produce this. It is women who are supposed to distribute this. It is us. Maybe the reason why we feel like this, it is because maybe even the DGs that you are talking about, that maybe they are not complying. I was going to be maybe out of order, Chair, and say maybe some of them are men. We'll have to get the statistics of who are these DGs who are not really monitoring this properly for us, so that we can understand who are we really dealing with here. It is important that we get to the bottom of this issue, because if we don't do that, we will be coming back here in the next 5 years or 10 years talking about the same issue. So if we know exactly who are we really dealing with here, who is handling this project for us, because it's our program, Chairperson. The other question that I would love to get clarity from Chair, these committees that are in the provinces, I want to also know what the composition of these committees themselves. The people who are handling this, are they teachers? Let's take, for example, in schools. Are they teachers? Are they SGBs, SGPV? Is it SGBs members? Or are the people that are being giving this responsibility not attached to the teachers, because I was going to say if we are giving this to the teachers, it is also, and it can also be a problem, because teachers are busy teaching. I know I used to be a teacher. If you give me something that I did not go to school to, not me alone, teachers will say, no, I'm teaching. My responsibility is to teach. Yes, I can assist other things, but for me to be given this responsibility for doing it every day, thinking how the strategies as to how I'm going to do this and this, it is sometimes become a problem for the teachers. Lastly, Chair, is the issue of the management of those committees. I understand that those committees are supposed to be managed by the DGs and the team, maybe the levels, according to the levels within the departments. But who is managing all this from the national level when it comes to the issue of oversight? Because we might be sitting here lamenting that things are not happening on the ground, only to find that we are supposed to be on top of the game from the level of the national, where we make sure that every month we get reports in terms of this, in terms of progress at the ground. Chair, I think, Chair, I'll pause. Thank you very much.
Thank you very much, Honorable Jelle. Honorable Drucken.
Thank you very much, Chairperson, and thank you for the presentation. I'd like to add my voice to, with regards to the provinces who are not implementing the sanitary program. I'm always asked, online to give someone in KZN some sanitary pads, but I see in 3 provinces it hasn't been implemented. So I just wanted clarity, why is it not implemented if the programs are there? And I also want to know, the schools have contact with the school district. Does the district assist at all to make sure that the schools receive the sanitary products? What is the cooperation from the provincial office to the school office? How does it work? Do they work through the district office, or how does it work? In the schools, when it's distributed, girls are shy, young girls are shy. They don't want to receive the sanitary products from men. So how is it then given to them in school? Then also the provincial MPL, do they know that these things are running in their provinces? Are they assisting? Is there any way that they can assist if they are aware of it? Then the second thing, national plan of action that the presenter mentioned with regards to the assessing the impact of the age appropriate comprehensive sexual education. So I'd wanted to know, what was the deadline for that assessment? Can we get a report on that assessment? Can we please get a report? And then especially with the schools for disabled children, are they also being assessed as well? And the integrated school health, program, can we also get more information on that later, at a later stage? Because I would like to read, from all the provinces, how it assists the province with my constituency, for example, what schools are covered in my constituency from the province. And then the special schools, like with disabled children, are they also then covered in this assessment? And I'd also like to just indicate, I face barriers in my constituency office here in the Western Cape, in the Swartland, to visit clinics and day hospitals, and they require permission from the MEC. But I am a member of parliament, so I would have to go and check where the tax money is being used, to check if the clinics and the day hospitals are working optimally. But they don't allow access. I can't ask questions about the queues or record keeping. I must get permission from the MEC first to be able to visit the clinic. So I still have to make a follow-up on that. But the barriers to us as MPs also in the health sector, is also an issue, so that we can follow up on these things as well within our constituency. I think that's it for now. Thank you, Chairperson.
Thank you very much, Honorable Suminya.
Thank you very much, Chairperson, and let me join my colleagues to welcome the presentation and welcome the good work that the Department of Women, Youth and Disability has done on this matter to expose the what needed to happen, which is not happening in the provinces. Just to question on the identification of these indigent, whether it's done through the committees, but whether these committees that are being established, are they linking with your social development or what councillors of those areas? Chairperson, I'm not going to repeat what other colleagues have said. Most of the things have been covered, but I just thought I must emphasize on this one. And if it's not done, I think there are a lot of systems that were put in place in identifying the indigent. Even the Department of Education has got this so-called quintal system that they use to identify these indigent communities. But to strengthen that, we should then be able to, if those structures are not involved, employ, that the department should be able to get a way of working with the those committees, working with the level of district or municipality, working with ward councillors, including constituency offices, just to see that the relevant indigent are being identified. The second issue is that, Chair, just to join you in welcoming the remark of the Minister, that at some point we should then be able to get the Minister and the team to come and present on these bank cooperatives and see how we can get a lot of women participate or supporting it. Of course, we have to understand the ideology around it, and therefore, so that we become the gospel distributors on the issue that is raised by the Minister. Thank you very much, Chair.
Thank you very much, Honorable Suminya. Now I'm going back to the department. Oh, there's a new hand. Honorable Mabizela, before I call the department.
Thank you. It's a quick one. I was just saying, as much as we have condoms all over, perhaps in future we can have pads, sanitary pads, maybe at the malls, on these kiosks where people find free condoms, But that could be a future thing, so that when you menstruate quickly whilst you are in town, you can just get a pad somewhere. It is just an afterthought whilst we are discussing. Thank you.
Thank you very much. Thank you very much. The department.
Thank you very much.
Mr. Machova, Mr. Shongwe.
Thank you very much, Chairperson.
Sorry, Chair. I can't hear the
Machova.
Yes, ma'am. Chairperson.
You're not clear. You are not clear. I don't know whether it's myself only, but I can't hear you.
Oh, am I better now, Chairperson?
Now you are, yes. I can hear you now.
Okay, thank you so much, Chairperson. I just wanted to firstly respond to the Honorable Bomba in terms of the provincial sanitary dignity committees, that the rationale for these committees was to ensure that there is integration or an integrated approach, as much as the implementing departments based on each province would be the departments of education or departments of social development. What we said was that it's important that the departments of education, social development, health, as well as the economic development department, because we talk about also empowerment of women, youth, and persons with disabilities, and also the department that deals with infrastructure, for instance, issues of water and sanitation, are important to be part and parcel of this particular provincial sanitary dignity committee, and that it should be convened through the office of the Premier. In other words, that the DG's offices should be the ones that are the conveners, because it's very easy when they are convened at the level of the office of the Premier, as against it being convened by social development or Department of Education. It just makes sense when it is convened from the offices of the Premiers. Now, just to indicate that the problem really is about functionality, because they establish them in name, but to find that there is dysfunctionality in the sense that meetings are not frequently attended. Some departments also default in terms of attendance. Hence, the situation as it is indicated in Eastern Cape, in Free State. And also to say in terms of consequent management, what we do is that we generate DG letters. For instance, from the Department of Women, Youth and Persons with Disabilities, we dispatch letters to the provinces to indicate these weaknesses. And also, since we have quarterly meetings as well, the report from the quarterly meetings as well goes back to the offices of the premiers and the provinces. So they are acutely aware of the challenges.
Excuse me, Honorable Chair. Honorable Chair, there is a disturbing noise behind the current speaker. I don't know, and they are over. We hear them more than the speaker, the presenter here. Those voices are more higher than
Mr. Machoba?
Yes, ma'am. Let me try to...
Can you continue?
All right. If I can then continue, ma'am, to indicate that that is what we have done in terms of what could be close to consequence management, is to highlight those issues to the provinces. But beyond that, we don't really have a particular stick, you know, in terms of IGR arrangements or policy. But these are issues that obviously we can be advised on. And then lastly, to Honorable Bomba, to just indicate that in as far as the implementation of the program by the departments in those provinces, KZN, apart from just the systems and controls that we're talking about, but KZN actually is able to reach the entirety of its beneficiaries, and they are doing well in terms of products reaching the schools. Followed also by the Western Cape. The Western Cape has done well in as far as that is concerned. And also the third would be Gauteng, that those, at least at the level of ensuring that these well-needed products do reach their beneficiaries, those provinces have actually been leading. And then the others, we are the ones that we are currently dealing with in terms of tightening controls. And then to Honorable Maseko, it will be important to also know which area is she referring to, where it appears that there has not been an efficient distribution, so that we can follow up on those issues, ma'am. And also to indicate that, yes, the distribution is to all quintiles 1, 2, 3 school, inclusive of special schools and farm schools. Even primary school learners are beneficiaries. And then at the level of procurement, indeed, we ensure that in terms of policy, women, youth, and persons with disability enterprises do benefit. In our analysis, provinces have done fairly well in as far as that is concerned, although it was difficult at first to accomplish that, but they have done well in the recent past. All that I can indicate is that mostly it is distributors that benefit a lot. Distributors, meaning that it would be service providers that would bid for this kind of service, then purchase these products and deliver to schools, more than actual local manufacturers. Because when it comes to local manufacturing, that is still a challenge that has to be worked on in terms of developing capacity for local manufacturers to be able to manufacture these products themselves. Because you find that in small pockets in Gauteng, KZN, Western Cape, and then there's also one activity in the Free State in Kwakwa, in Chaba. So there is still a concerted effort to ensure that together with the Department of Small Business Development, SIDA, SIFA, and other institutions, we are working on ways and means of creating incubation programs in order to capacitate women, youth, and persons with disabilities to have this ability to be able to produce these well-needed products, have access to machinery, raw material, etc. And then in terms of the Honorable Johan, let's keep it that. In terms of the comprehensive sexuality education, the study that is going to be conducted is going to start in the month of October and will be completed by March of next year. It does include, yes, special schools as well. So the program, the study will continue as soon as the following month. And then in terms of
Sorry, I can't hear you. Can you speak closer to the mic, please?
Certainly. In terms of the integrated school health program, that program is under the auspices of the Department of Health, which includes the Department of Education, Social Development, ourselves as a Department of Women, Youth, and Persons with Disabilities, where we comprehensively speak on issues that affect learners in terms of menstrual health or reproductive health and rights issues, so that we can have a comprehensive picture and appreciation of the kind of programs that we are dispensing to learners in education institutions and areas of improvement. So that is continuing, and we think that is going to create a lot of positive results, because we sit as departments, especially within the social sector or within the social cluster, so that we can collectively be able to manage and mitigate some of the challenges that arise. And then to the other in terms of the committees or local committees, they are composed of the school principal as well as the SGBs are involved. They also have learner support agents as well as life orientation teachers. So it basically is composed of people that are inside the school. And then, of course, in the SGBs, you have also members from the communities. So that is the composition of those committees. And they also link up with the district education authorities. And then the district education authorities are the ones that then take the information back to the province. So there is that relationship between the provincial, the district, and the local committees in order to ensure that there is a better monitoring of process. And then it's one of the innovations that need to be thought through in as far as in future, how do we ensure that there is access beyond just distribution of these products through service providers, but can there also be pickup points for menstrual products, whether it's in clinics, whether it's in specific malls or specific shops or post offices, but to have centers where people can just simply, the indigents, as they would have been identified, can just go and pick up instead of over-reliance on suppliers that come to the schools. Thank you, ma'am. Thank you, Chairperson.
Thank you very much. Thank you very much for your responses. Honorable members, we are now at 12:20. We still have one department, which is Department of Health, to present. I just want to check with you whether giving them the opportunity now to present will be able to engage with them, or any proposal. Do we give them the opportunity to present, or we ask them to come and present next time, bearing in mind that we were scheduled for 10 until 1 o'clock? Honorable Maseko Jelly.
Thank you very much, Chairperson. I think that can also be determined by how long is the presentation that they're going to give to us, because indeed, if we can make sure that by 1 o'clock we are out, because we still have to attend to other election work on the ground, it will be very helpful. But as long as the presenters can assure us it is the presentation is within the 1 o'clock schedule. Thank you, Chair. We can continue.
Can I check with the department?
Good afternoon, Chair. Can you hear me?
Before I take the hand. Yes, I do.
Yes, it's Manala. I'll be the one who's be presenting. Yes, I can assure you that we will be. I'll take the presentation will take exactly 20 minutes. So if I start now, I'll be done by 10:02 and take some few questions, and so that we are ready to adjourn by 1 o'clock. Thank you.
No, thank you very much. We got the assurance now that the presentation will take only 20 minutes. To the Department of Women, Youth and Persons with Disability, the Honorable Minister, thank you very much for your presentation. And I will concur with Honorable Siminya to say the caucus will love maybe to call the department to come and present for the initiative that they have of a co-op. And also maybe to call the provinces to come and account, because issues that were raised by honorable members here, I think they needed the provinces to come and account. Thank you very much. Can I hand over to the Department of Health? Over to you, Ceci.
Thank you very much, Honorable Chair, and good afternoon to the colleagues. And as they are bringing up the presentation, maybe what I should do, if I'm allowed to shorten my presentation, is also to take some of the questions that were raised and were actually directed to health directly or indirectly. So I will, as I present, I'll take some of the questions, but I'll indicate what are we doing in that regard. So let me start first by, if they can put it on a slideshow, I would appreciate. Let me start by acknowledging the team that put together the presentation, and they are also supporting me. I've got a couple of directors and deputy directors who are joining me in this presentation. So what I'll do is I'm going to take you through the presentation in a manner that I would not go into details of the areas where they've been touched on. I know when we're dealing with social cluster issues, it's very difficult to differentiate between the activities that are done by different departments. They cut across, which talks to this very first slide where we had a very detailed presentation around the disturbing issue around the rising deliveries of children who are between 10 and 14 years. So this was just actually highlighting that the situation is worse in KZN, and there are some activities we know we are dealing with different approaches to try and cap this, because we know it's multi-sectoral, multifactorial, and requires the whole society approach to respond to this, because I think we need to really understand what is actually happening if we have 1,254 babies giving births during our watch. What are we actually doing? I think as a community, we need to make some sense of what are we actually doing. So what actually I'm going to take you through is some of the activities that we are doing in the Department of Health. Next slide for me, please. So I'm not going to be reading word for word. So I'm going to be asking the person who's moving the slides to move as I've covered the gist of the presentation on the slide. So actually, as a department, we went out to the communities, try to get an understanding to say what has happened to the community to have babies giving births. And obviously, if they give birth, there are also those who fall pregnant and then they don't carry babies to term. And also it means that there are also those who are engaging in sexual activities that we are not capturing. So actually what we are reporting through the District Health Information System of the Department of Health is actually a tip of an iceberg. The question is, what is the actual iceberg, and what are the issues that leads to that? So we have been conducting the dialogues, and engaging with young people, trying to get all this. And then thanks to our Deputy Minister who could not join us in this presentation, being the face of the Department of Health in engaging with all those dialogues, trying to understand exactly what are the young people dealing with in all that. And secondly, there's a whole issue around termination of pregnancy. I know it was also touched with the questions to say, what are we actually doing in terms of termination of pregnancy, and how do we balance it with the illegal abortion on that? So we also had a roadshow across all the provinces to deal with all that. But what we've done in the Department of Health, we've put together a couple of guiding principles in terms of policies, in terms of guidelines. And really, I know it could sound like the guidelines are many, but what I will do is I'll just highlight one area that is actually a message in each of the policies that you are putting together. So the first one under maternal, newborn, and child health, because we've realized that it's a continuum. We summarize it as a first 1,000 days, meaning it's from pregnancy, antenatal, and postnatal, and the first the few years of life. So the message we're saying there is we're taking an approach of a continuum, trying to follow through from pre-pregnancy all the way down and identify the key areas that are still contributing to the maternal and mortality issues within our country. So in terms of sexual and reproductive health, if we can move to the next slide, because the next slide is actually taking us through those guidelines one by one, and then I'll tell you what each one of them is focusing on. So the first one that is talking to the contraception clinical guidelines. What we are addressing there is contraceptives have been available, the method mix has been expanded, but we're still seeing a phenomenon where the uptake of methods is still skewed to particular methods. You'll see that in the next slide. So we're trying to promote other forms of reliable contraceptives, and the ones that are actually long-acting but reversible. Really, the focus there is to say we need to make sure that the uptake is focusing on things that would not require repeated visits to the healthcare facilities, already managing the issues around the visits, the queue, the attitude, and all that. Because if you have, for an example, the intrauterine device that will take you 10 years, actually you don't really have to deal with all those issues associated with the uptake. So that's one issue that we're pushing with that guideline. The whole issue, the guideline around safe conception and infertility is that we are actually acknowledging the fact that we are dealing with a broader cohort from 15 years all the way to 49 years. And therefore, in that cohort, we also have a proportion of women who are struggling to fall pregnant, despite the fact that others are falling pregnant unplanned and untimely, or even at a very young age. But the safe conception really is to say, let's give an opportunity. Earlier on, somebody touched on the issue around HIV. Okay, that's from status A. So, and the prevalence. And you've noted that actually we're having a lot of women now, more than 60% of women who already are on ART that are falling pregnant. So we need to make sure that they have a safe pregnancy, because they need to exercise their right to have children. So really, this guideline is focusing on making sure that we allow them that opportunity. What to do, the issues around the viral load suppression, early antenatal care, that guideline is responding to that need. And if we look at the next guideline that is talking to the pre-exposure and the post-exposure prophylaxis, really it's about an emergency care and preparedness to try and respond to what happens. And I know we're coming from the situation where it's commonly known as emergency contraceptives was mainly associated with the either a rape or incest or whatever. But this guideline is really saying, this actually says for anyone who had sex without a protection need to have access to this. So we're trying to respond to the call of saying improving access. So the guideline was just broadening that, whether it was professional, whether it's occupational, whether it's non-occupational, whether it was a leisure sex or whatever, everyone else is eligible to get the prophylaxis if it happens out of plan. The next one that is talking about the breast cancer, it was also touched from the Stats SA that we are seeing a very alarming number of increase in incidences in breast cancer, and the mortality it's about 50%. So what we actually introducing in that guideline, we actually introducing two concepts. The first one is breast cancer for a long time has been the high level care, which was only managed at the central hospitals and tertiary hospitals. So in that guideline, we're trying to put together the systems to make sure that we are decentralizing the care, especially in early care where we need surgery. So the surgery for the management of breast cancer does not have to happen in high institutionalized or high level hospitals, but could still be done at regional level. So that guideline is really to support clinicians who are supposed to do that, but also to introduce the clinical breast examination. We know we're coming from where we were saying self-breast examination, which is part of self-care that I'm going to touch on later on. But again, we're saying we're missing opportunity from the clinical care. So if you visit a facility, it's an opportunity to get your breast examined clinically with insight, and also provide and use that as a teaching and opportunity. That's the key issue around that. But the issue around the choice and termination of pregnancy, I know most of you are very familiar with this from the ACT point of view, but the issue we're bringing in this guideline as one of the things that we're managing is the introduction of the medical termination of pregnancy. So what we're saying is people have been used to being hospitalized, getting to being to go to theater for the manual evacuation and all that. But actually we're saying if you report pregnancy early before 10 weeks, you're actually eligible for the medical abortion, meaning you just have to take a tablet that does not require you going to theater or anything else, because we've realized that one of the issues of a poor uptake in this is people's fear of going to theater because it's a bad connotation, or the evacuation procedure because it's very invasive. But then we were introducing the non-invasive method, and if it's been used, and then it will actually improve. And then the key issue around the next guideline, which is about preventing mother-to-child transmission, we've come a long way. We've reduced the mother-to-child transmission from 30% to now we are sitting at 0.44%. while it's a 0.44%, we are no longer counting now in a percentage, we're now counting it in actual cases. So this guideline is actually an introductory point where we're looking at a path to elimination. So which means that all the prevalence rates and all, we're capping it at an incidence so that we shouldn't have babies who are delivered with that. So we're now monitoring the cases, we are on the path to elimination. And I think as a country now, we are ready to now apply for the bronze, which means we've reached a situation where we're reporting less than 750 cases per annum of the mother-to-child transmission. So we actually really appreciate the effort of the collaboration of all other members with all the efforts that have been put together to make us get to the elimination space. In terms of cervical cancer, I know there were two issues that were raised with this, issues around HPV vaccination. Yes, we are aware that we are now 9 years in the implementation of the vaccination program, but unfortunately the cohort, while we cover 80% of the learners who are eligible for that, the cohort is very narrow. We're focusing on 9-year-olds. And for us to accelerate this, we are looking at options to expand the cohort to also include the private schools so that we cover more young girls. And we're also looking at the possibility of other resource mobilization to make sure that we broaden it to include the 9 to 15-year-olds and not only 9-year-olds, so that we accelerate the process in terms of including the rolling out the HPV vaccination. There was also an issue around the screening. Yes, we have been doing the cervical cancer screening, but this guideline is actually introducing alternatives to say we're now looking at transitioning from the cytology-based to the HPV screening, which is actually going to have more benefit, is going to detect more cases, we're going to miss fewer cases, and then it's less invasive also, and we're looking at that as a way forward in trying to respond to the improving the screening. As I've indicated, I'll also touch on the issues as they've been mentioned. So the STI clinical management, yes, I think this is another area where we're grappling with in terms of women's health, that we're seeing a re-emerging of conditions that we thought we've been eradicating. One particular one is the syphilis. I think we've just had the antenatal survey, that 2022 data released, that is actually also still reiterating that we're seeing the resurfacing of syphilis. So the guideline really is to say increasing awareness, alertness. While people are not having HIV, it's not only about HIV now. Syphilis is also debilitating and also transmissible to babies. So we need to have the clinicians focus on that. That's what we're trying to, what is the message around that guideline? So the last guideline, which is talking about the self-care interventions, is going to be, I'm going to talk to it when you get to the next slide, please. Next slide, please. Can people still hear me? Yes, okay, thanks. So before I get to the self-care guidelines, is really to say one key area that we've realized is that in implementing all those guidelines, there's many as they seem, it's about capacitating the clinicians, because if the clinicians don't know what to do and they don't have access to that information, it does not translate to actions. So we've put together what we call an SRH training module, which is very structured, is online, is continuous, is accessible at any time, is staggered to different clinicians, medical officers, nurses, community health care workers, anyone else. So it's got different, so it's a very broad training curriculum. The purpose really is just to top up the basic in training that is happening at the facilities. Can you go to the next slide, please? So it's got different modules. So the self-care interventions really was to, we're looking at gearing up towards the universal health coverage of leaving no one behind. So most of those guidelines that I've indicated, actually they've broadened up to include the marginalized communities, the people living with disabilities, and some of the LGBTQI needs in responding to that. And then we've been doing a lot of primary healthcare approach, like I've indicated, we're going down, decentralizing some of the services that were centralized hospitalized for a long time. But the topic that we were given also was the issues not only about access, but there was also an issue of quality of what we are providing. Much as we're saying we're providing a wide range of services, what is the level of quality of that? So we've implemented what we call the Mpatalatane project, which is really a project that it could take me a long time to try and explain what is it all about. But what we're saying with Mpatalatane, which means this is a sort of word, I think it's in English is translation to the rising star. So early morning rising star. So what we did with Mpatalatane really was to try and deep dive into understanding what are the nuances around the issues around access, issues around the quality of service that is being provided. So maybe if we have an opportunity, we can come back as a department and present this whole quality improvement project to it. But also the issue of health promotion was also mentioned, to say we need to strengthen issues around health promotion. I think we, from health, we've been moving around, we've developed different programs, the She Conquers, with the BYs and all that, digital-based, face-based, really to trying to conscientize everyone on issues around teenage pregnancy, the rising new infections, the issues about gender-based violence, and how to the dropout in school, all the programs that we're doing with other sister departments in trying to keep the girls in school, how to reintegrate them post-delivery, and creating the youth zones, allowing them to go to facilities, the health facilities after schools, and not to miss classes because they have to attend the antenatal care, and many other issues that we've been dealing with. So we agree that there's still a lot of work to be done, but we've done a lot so far. I think the recommendation is, how do we then I think what Mr. Next slide, please. How we want to do it, we know. I think what we need to deal with, it's coverage. And then with coverage, then it says we need to take this in terms of access and quality outside the healthcare facilities. So we need to, in healthcare, we're working more towards integration, so that it's not about HIV, it's not about pregnancy, it's all about patient-centered care and all the services provided either under one roof based or under one room based on the size of the facility that is providing care. And those models have been tested in different parts of the country. We've tested the under one room in Eastern Cape, and then we've tested under one roof in Utugela district in Kenya. There are variances in implementation, but we know we've tested all that. And also looks at, as this is a real societal approach to say, where are we as community, as women, as moms, as whoever else that is